Welcome to today's webinar, Fundamentals of HIV Infection and Applications of Antiretroviral Therapy. I would like to introduce Michael S. Saag, MD, Professor of Medicine and Associate Dean for Global Health at the University of Alabama at Birmingham, and a volunteering member of the IAS-USA Board of Directors, and David H. Spach, MD, Professor of Medicine, Division of Infectious Disease at the University of Washington School of Medicine, and Principal Investigator at Mountain West AIDS Education and Training Center. Welcome, Dr. Saag and Dr. Spach.
Thank you very much, and welcome everybody. We're going to go ahead and get started. Dr. Spach and I are very pleased to do this webinar again. A couple of housekeeping items. First off, if you go to the www.IAS-USA.org website, you can update your account, and this will be a very important way for you to keep up with your CME and registering for other activities. The CME information for the IAS-USA is it itself is accredited by the ACCME for providing continuing medical education for physicians. This educational activity will have 1.5 AMA PRA Category 1 credits. We also will provide nursing credits at 1.5 credit hours, and for pharmacy credits, which will be 1.45 hours and 0.15 CEUs. The evaluations will be available in your IAS-USA My Activities webpage by 5 p.m. Pacific time today. That's 8 p.m. Eastern time. And once you get to the website at that time, you can claim your CME credits, and you'll also get a certificate of participation. If you're not receiving the emails from IAS-USA, go to the website to get more information. The grant support for this webinar is provided by unrestricted educational grants from the following companies listed on this slide, and they have no input into the content or selection of speakers, but their funding is important to help defray cost of these types of activities. On the webinar, we're going to have some poll questions, and we're going to try that out today. First off, we're going to be asking questions that you'll respond to, and I'll do that in just a second. But also, if you want to ask questions, there's a chat box. I think everyone's finding that right now. So as the webinar goes along, put your questions into the chat box. We'll collate them. We're going to go through the presentation in its entirety and then leave about 15 to 20 minutes at the end. So this will be around 2 o'clock or 2:15 Eastern time. We'll be able to address the questions, and we'll take them in order and get through as many of them as we can. So let's try the poll question here. This is pretty straightforward, and you see the poll number 1 has come up. Just click the answer that best selects where are you from. Okay, I think everybody's getting the hang of that. Let's see what the results show. And we'll broadcast that out. Good. Okay, so we're kind of all over the country as we expected. The next question, when will the evaluation materials be available? I just said that, but let's see who is listening. Okay. And it looks like a few people went for the moon in your eye like a pizza pie, but most people got it right. So yes, by 5 p.m. East Pacific time today. And the final question here, what is your current, if you were to define yourself, level of expertise in the medical management of HIV? Go ahead and vote. All right, so it looks like, as intended, this is a kind of an HIV 101, although it may go into 202 at certain points, but it's meant for people who are relatively new to the field, and it looks like we have a large number of folks that meet those criteria, and everyone's welcome. It's just to make it clear that we're pitching this for folks who are just getting into HIV care maybe over the last year or two. Yeah. So we're going to go ahead and start the program now, and I'm going to turn things over to Dr. Spach.
All right, Mike, thanks very much. Just for the financial relationships, I don't have any private financial relationships, and Dr. Saags are listed here. All right, the overall learning objectives for this webinar are going to be for Mike and I to summarize the events of early HIV infection. I'm going to focus on these first three. Then to list the sequence of laboratory markers following HIV acquisition, then describe some basic mechanisms of the antiretroviral therapy drugs. And essentially, I'm going to set the stage for Mike, who's really going to get into more of the nuts and bolts of the clinical related to selecting antiretroviral therapy in patients who are starting initial therapy, have persistent low-level viremia, or pregnant, or considering pregnancy, or experience virologic failure or any antiretroviral resistance. So the topic for mine of what I'm going to focus on specifically are those first three objectives that I just went over. And hopefully this will, again, give you some insight and I think set the stage for what Mike's going to cover with some of the more clinically focused. So we have a couple pretest questions. The first one is, following acquisition of HIV-1, when is plasma HIV RNA first detectable with conventional HIV-1 RNA assays? So it's 2 days, 4 days, 10 days, 20 days. I think everybody's seeing the question. Okay, I think you probably, okay, great. And then we'll close that. And then the second pretest question is, which one of the following medications inhibits HIV by binding to the D2 receptor of the host CD4 receptor? Is it Maraviroc, Ivolizumab, Infuvritide, or Bictegravir? Okay, great. Well, we'll address both of these during the talk here. All right, we can close that. And what I want to do to begin with is to talk a little bit about some of the early events that occur with HIV infection. I'm going to focus on some of the basic pathogenesis and then talk at the very end about how clinically we should treat individuals with acute HIV. First of all, from a conceptual standpoint, when individuals are infected with HIV, they're infected with the quasi-species of viruses, and this is assuming somebody does not have suppressed HIV RNA levels. During the transmission of the virus, though, however, even though there are all these quasi-species that may be exposed to another person, there's usually only one or two viruses that actually get transmitted and start the infection in the individual who's acquired the HIV. This virus that essentially makes it across to the other person is called the founder virus. And looking more at the mucosal level, and this is basically just showing you at the genitomucosal level, there are a number of different viruses that can interact and interpose with the mucosal surfaces, but again, not all of them have the right stuff that leads to the actual transmission of the virus. And this is just giving you some example that if it's the wrong tropism, if it's a defective virus, if it's a less fit virus, but there is this one virus that essentially can transmit. This is almost always what we call HIV R5 tropic virus, and essentially this is the very first event that occurs on day one of the infection. Within the first 2 to 4 days, there's local proliferation. Usually the initial infection is in a CD4 cell, and usually the initial proliferation is coming out of CD4 cells, but it may start to involve tissue macrophages as well. Some of these CD4 cells, if they get activated, really ramp up this initial stage. By day 3 to 7, there's some spread of these CD4 cells and macrophages to essentially facilitate the transmission into regional lymph nodes is shown here. And then you're really off to the races at this point because the virus is really getting into the regional lymph nodes. And then the next phase, there's the very early regional and basically dissemination through the bloodstream. And as you can see here, this very homogeneous virus is just starting to diversify a little bit at this point, where you may start to see some new quasi-species starting to emerge. But essentially, this is the early hematogenous dissemination that occurs at about day 7 to 10. And then it's about day 10 when we first are able to detect the virus in the bloodstream using HIV RNA assays with conventional HIV testing. So now let me shift gears to focus a little bit on some of these laboratory markers that we see early in infection and get a good handle on why we do HIV testing the way we do now, even for routine screening. So as I mentioned, it's about day 10 when we start to see the virus becoming detectable with conventional assays above the level of detection. And it's important to understand that by about 1 month, the level of viremia is typically very high in individuals with acute HIV who do not get antiretroviral therapy. These levels are typically 100,000 or above, and often above 1 million. So very high levels of virus, and this contributes to the notion that individuals with early untreated HIV are very highly likely to transmit the virus to other individuals. So the HIV RNA is the first marker for laboratory testing that becomes positive. The second marker that can become positive is the HIV P24 antigen. And as many of you know, the HIV P24 antigen test is part of the common, what's previously been referred to as fourth generation antigen antibody test. Now we typically just refer to these as just HIV 1-2 antigen antibody test. But that is the initial screening test with HIV, and it includes the P24 antigen. So you can see this occurs about 7 days after the virus is detectable. So thinking about this, day 10, the RNA is detectable. About day 17, the HIV P24 antigen. And about a week after that, HIV antibody using newer IgM, IgG antibody tests usually are positive. So really there's this pretty predictable sequence of events that occurs, and kind of an easy way to stack this up. And again, this is a little bit simplified, but think of it, to hang your hat on this, essentially the HIV RNA is detectable about day 10, the P24 antigen about a week later, day 17, and then the antibody about day 24. So those are kind of the numbers to hang your hats on, 10, 17, 24. Now, looking at diving this a little bit deeper, you can look more linearly at how these labs turn positive. And again, this sort of stacks up the HIV RNA about day 10. Notice the green bars there are the antigen antibody tests that include the P24 antigen test. But notice that the laboratory-based test, the one on the left, becomes detectable 3 to 5 days before the point-of-care tests that are done. The antibody, there's basically the same story. Using the laboratory-based IgM, IgG, newer antibody tests, those are detectable usually by day 25, but the point-of-care tests that you may be familiar with, the oral testing and even blood testing with tests like OraSure and OraQuick, these are really delayed out past day 30, usually after a month. And as you can see here, the Western blot performs very poorly for detecting people early, and we don't use the Western blot in any routine standard testing now. So here's another point or concept. There is a period where individuals can be infected with HIV, but not actually have any laboratory tests that will detect the infection. This is referred to as the eclipse phase. We like to think of this as infection to detection. And again, this is about 10 days because that's the time period when the HIV RNA test is going to be turning positive. And obviously the eclipse is giving you the sense that you can't see it there, but the individual actually has the infection. A second concept regarding this is that during the time when people present with acute illness, and roughly 50% or more of individuals will present or will develop some kind of severe acute mononucleosis or influenza-like illness. And when that occurs, it's typically at a time where the viral load, the HIV RNA, is readily detectable, but the other labs are not 100% predictable. So if a person presents a little bit later on the spectrum with acute illness, more on the right of those bars, you can see the viral load should be positive, the P24 antigen should be positive, but the antibody would be negative. Some individuals present very early after infection with starting to develop symptoms. The far left there, and you can see the viral load, HIV RNA, will be positive, but even very early, some individuals will have a negative P24 antigen. So the take-home point of that is that if you strongly suspect acute HIV in an individual and you do an antibody antigen test and it's negative, but you clinically suspect it, you may need to then go directly to doing the HIV RNA test. So from the CDC algorithm, this sort of follows logically thinking about what labs we do for acute HIV, for screening, and how it might pick up an individual who had very recent infection. So the screening test recommended by the CDC and that most laboratories are now doing is the HIV-1/2 antigen antibody test, and that includes the P24 antigen. Usually with acute infection, that initial test will be positive, but the differentiation assay which is called the Genius test, will be negative because they haven't had time to generate their antibodies. But then you go on and do a tiebreaker test, the nucleic acid test, the HIV RNA test, and that should be positive. That is the typical scenario for what you should see when doing routine screening and diagnosing somebody with acute HIV. As I mentioned earlier, there is this situation where somebody may be presenting very early, or you're just screening. But if you strongly suspect, and they have a negative initial antibody test, but you strongly suspect acute HIV, that's when you go on and directly do the HIV nucleic acid test. So here's a question just to finish off the discussion about acute HIV. It's important to make the diagnosis, but what's even more important is to know we want to immediately jump in and treat individuals. So here's the question for you. A 24-year-old woman is diagnosed with acute HIV. A genotypic HIV drug resistance test is ordered. The plan is to immediately start antiretroviral therapy. Which one of the following regimens is recommended in the HHS antiretroviral therapy guidelines for this situation? Would it be elbapordrol, tenofovir DF, emtricitabine, or elbapordrol, tenofovir alafenamide, emtricitabine, or number 3, raltegravir, tenofovir alafenamide, emtricitabine, or number 4, darunavir, cobicistat, tenofovir alafenamide, emtricitabine. So this is a fairly difficult question, and we're seeing a scattering here. And the correct answer, but not the only option, is going to be, let's see if we close this down now in a second. We've still got a couple people responding. Okay, great. So the poll's closed. The correct answer is actually number 4, darunavir cobicistat. And what this has to do with is that if you do not know the genotypic drug resistance test result like this situation, you want to make sure that your initial regimen has an anchor drug that has a very high genetic barrier to resistance. Mike will go into this in more detail later, but with that said, darunavir cobicistat and dolutegravir are drugs that are recommended in this situation because they have very high genetic barrier to resistance. Okay, if we can close that window out, and I'll move on. Okay, great. So here's the summary then, just a couple key points about treating individuals with acute or very early. As Mike's going to talk about a little bit more, we really are trying not to delay getting people on therapy. You want to jump in right away if you can on the same day or within a couple days and treat individuals with acute HIV. We want to treat all individuals with acute HIV. Before giving them any medications, you want to make sure and order an HIV drug resistance test. That may take weeks to get back. You can initiate antiretroviral therapy before that resistant test comes available. And the current highly recommended regimens in this setting are, again, anchor drugs with very high genetic barrier to resistance, boosted darunavir or dolutegravir, plus either TDF-FTC or TAF-FTC. Now, most experts would say that bictegravir plus TAF-FTC would also fit this very well, and we likely will see that in the next rendition of the antiretroviral guidelines, mainly because of the very high genetic barrier resistance. And then you can modify the regimen if needed based on the drug resistance results. So now I'm going to shift gears and spend the next 10 to 15 minutes focusing more on the mechanism of action of these antiretroviral drugs. And as you use these medications throughout your career, I think it's important to step back and understand how they work. And when you understand all the mechanisms, it's a very important point for being able to understand how resistance develops and to understand when new medications come out and they're described as, for example, a post-attachment inhibitor. What does that actually mean? So that's what I'm going to go through. Now, to begin with, it's good to take a bird's eye view of this interaction that occurs between HIV and the host cell. And basically, there's a complex interaction where the virus, starting from left, moving to right, interacts with the host cell receptors, enters the cell, basically converts its RNA into DNA, which it allows it to be essentially in a form that it can be transported into the nucleus and stitched into the human DNA, integrated into the human DNA. This HIV DNA is then transcribed, both to messenger RNA and then to viral RNA, and the polyproteins that are made, the viral polyproteins then are synthesized, moving, yes, thank you very much, they're moving over to the right. And then as the virus accumulates these elongating polypeptides and they move to the membrane, they pinch off part of the cell membrane and then bud off from the cell, mature further with some protease action, and go on and infect other cells. So the end result of this are these rounds and rounds of viral replication that occur, and you produce a lot of virus, but it takes a toll on the cell, and these CD4 cells or these host cells are actually destroyed in this process. And we now have really sort of four major points of viral inhibition. And to begin with, we have to the left the entry inhibitors that block the virus entering in the cell, and I'll dive into that a little more detail because there's several different steps. Then we have the reverse transcriptase inhibitors, the nucleoside reverse transcriptase inhibitors, the non-nucleoside reverse transcriptase inhibitors, and then we have the integrase inhibitors that block the virus from being integrated in the DNA, and then the protease inhibitors. So I'm going to go through each of these steps one by one and try and highlight these four major steps. Before doing that, though, I think it is important to think about conceptually what are we doing when we're giving these medications. And there's really sort of three major ways that we block viral replication. One is, and the most common, is that we inhibit or we do something to the viral HIV enzymes, the key enzymes, reverse transcriptase, integrase, or protease. There's one drug, enfuvirtide, that actually binds to a spot on the viral HIV GP41, so it binds to the virus directly and inhibits a structural component of the virus. Then there's two drugs that work by blocking or binding to the human or host receptors, which brings up a number of issues in terms of could they interact or inhibit human host responses and immune responses. And those are binding at the CD4 region, the D2 region, and that's ibolizumab. And then there's drugs that can work at the CCR5 co-receptor, and that drug is maraviroc. Now, again, the classes that we're going to focus on and that Mike's going to focus on are going to be the main enzyme inhibition, and that's going to be the reverse transcriptase inhibitors, the integrase inhibitors, and the protease inhibitors. But to begin with, let me focus in on HIV entry. So the HIV entry process is really a complicated three-step process, and I'll try and distill that down and break it down a little bit. But these three steps include attachment to the CD4 host receptor, binding with the host co-receptor, and is shown on this schematic here, either the CCR5 in blue or the CXCR4 in purple. And then the third step is fusion, where the viral membranes and the host membranes fuse, and then essentially the innards of the HIV get injected into the host cell. So I'm going to focus on the most common pathway with the most common virus, the so-called R5 tropic virus, which enters in through the CCR5 pathway. That's what occurs almost always with initial infection and early on when people are infected. As I mentioned, though, the virus can enter in through the CXCR4 pathway, but I'll focus on this. So think of this as that the virus has got to come down and almost like a lunar landing here and interact with these different components. And this is schematically showing you the host cell with the CD4 receptor and the CCR5. Now I'm going to blow this up further now in the next slide. And now imagine again the virus is on top, like a lunar landing coming down, and looking at the key components of the outer surface of the virus, the surface proteins that are very important, called the HIV envelope. And at the top, there's the GP41, which is essentially like the legs of this surface of the protein. And then there's the GP120, which is like the outer knob that first interfaces with the host. So there's going to be this complex interaction that occurs with the virus coming down with its outer envelope interacting with the host proteins. And that's what I'm now going to focus on. The interaction that first occurs is with the CD4 receptor. That's step one. And on the virus, you can see the component on the GP120 that's important is the CD4 binding site. So now with the virus moving down, it will land and interlock with this first step of CD4 binding. We call this attachment. So anything that happens after this is going to be called post-attachment or post-attachment inhibitors. So the virus interacts with the CD4, and then there's an important thing that occurs after this attachment occurs. There's a central part of the viral envelope, or GP120, that is really fluid, and it moves down towards the CCR5 co-receptor and then interacts with the co-receptor. We call this the V3 region. This is step two. This is the interaction with the host co-receptor. So there's the attachment, step one. The co-receptor binding is step two. Now the third step is more complicated. And schematically what I'm showing you here is that binding of the GP120 with the host co-receptor triggers the springing and unspringing and unfolding of the HIV GP41 region. Thank you very much, Mike. Mike's driving this, so this is perfect. So the GP41s unspring, and there's a terminal area of that latches on down in the yellow highlighted area to the host co-receptor. So this essentially jettisons off these GP120 envelopes and allows now for essentially the virus to really grab hold and grab on to the host now and the host membranes. So this is showing you now a little bit more unveiled with 2 or 3 of these already having sprung out. But importantly, the GP41 has these 2 regions called the heptad repeat 1 region and the heptad repeat 2 region. And these regions essentially act like 2 pieces of Velcro that fold back on each other. And if you kind of use your imagination here, you can imagine that as they fold back, that this will pull the membranes together, and you'll have the fusion of the HIV membrane and the host membrane. And that is the third and final step of viral entry called fusion. Now, let me jump into how we block these different steps. So again, step one is the CD4 binding. The drug ivilizumab binds to a component of the CD4 receptor called the domain 2 region. There's 4 regions, 4 domains as shown here. This is very important to understand that it binds to domain 2 because this does not prohibit domain 1 from binding with the HIV. The other thing that's very important is domain 1 is very important in terms of binding with major histocompatibility type 2 antigens. So ivilizumab is believed to be essentially non-blocking of host immune functions, but as I'm going to show you in a second, once it binds, what can happen in the next sort of schematic is that as the virus comes down and it does bind to the D1 region, this locking on of ivilizumab to the D2 region really blocks moving a little bit lower down the fluidity of the viral GP120 movement, and essentially that second step of binding to the co-receptors is blocked. So we call this post-attachment inhibitor because the virus is already attached, but then nothing else happens downstream from that because of the ivilizumab. And it's a humanized monoclonal antibody. Now moving on to the next step where we can enter. This is step 2, and this is showing you how maraviroc, the CCR5 inhibitor, works. Maraviroc directly binds to the host co-receptor, but only to CCR5 receptors. And I'm not showing this exactly schematically, but what actually happens is it doesn't just block the actual physical interaction. What it really does is it causes a big conformational change in that CCR co-receptor, leading it to be in a shape and form that prevents that second step of the GP120 binding to the host co-receptor. Now, because that drug only binds to the CCR5 host receptor, it will only work if you have pure R5 virus in the individual who's infected with HIV. So there's a test that we order called an HIV tropism testing, which is really just sorting out to the far left, do we have R5 virus? Do we have X4 virus, or do we have a mixture of these? And again, Maraviroc will only work if we have pure R5 virus. So that's the whole purpose of the HIV tropism test. Now, the last drug to mention in this is the drug enfuvirtide. So enfuvirtide, shown down on the bottom in the blue, is a 36 amino acid peptide that's genetically synthesized as a corollary, and it really is essentially what the HR2 region is. So essentially you're synthesizing the HR2 region and giving it to an individual by an injection. And I should have mentioned ibalizumab is given intravenously. This drug enfuvirtide is given subcutaneously. So this is a little bit complicated to understand, but think of this as being essentially a small HR2 region that you're going to give to the person. Now back to this unfolding and unspringing that's occurring. So the enfuvirtide, because it looks exactly like the HR2 region, binds to the HR1. So again, using this Velcro analogy, it's sort of like you stuck it on to the Velcro component here, and it can't fold back on the HR2 region. So enfuvirtide, again, very small compound peptide, 36 amino acids, directly binds to the HR1 region and prevents the folding back, prevents the third step, or fusion. Now I'm going to move on to the reverse transcription and the reverse transcriptase inhibitors. The reverse transcription is a process that involves HIV RNA conversion to HIV DNA. And the key enzyme in this is the reverse transcriptase, which facilitates this process. Importantly, the building blocks for this used in elongating the HIV and turning HIV RNA to DNA are the human nucleotides. That's what the reverse transcriptase uses. As the virus is elongating, it has a template strand that serves as the base, an elongating primer strand where the new nucleotides essentially are added on one by one through the facilitation of the reverse transcriptase enzyme. Now, what we do when we give reverse transcriptase inhibitors, the nucleoside reverse transcriptase inhibitors, we're giving drugs that are synthesized to be very similar to the normal human nucleotides, and therefore the virus mistakenly, reverse transcriptase picks them up, adds them on, thinking they're a human nucleotide, but they're structured in a way that nothing else can be added on. What this does is it causes primer blocking. The primer strand is blocked, nothing else can be added on, and the end result is a process we call chain termination. So essentially you're fooling the virus with decoy molecules when you're using nucleoside reverse transcriptase inhibitors. In contrast, the non-nucleosides directly bind into the viral binding in the NNRT binding pocket. So these are drugs that are synthesized to flow right in and mechanically obstruct the reverse transcriptase inhibitors. And this is very near a very important site called the polymerase active site. Great, thank you. Now, so when the drugs are given, they fall into this pocket. They directly cause a couple of things to happen. The first thing they do is they cause this hyperextension of a thumb region, probably some extension of that front part called the fingers region as well, and they alter the direct binding at the polymerase active site. So it's a multiple process that occurs, but the easy way to think of this is that it's just getting in there and jamming up physically the enzyme that is responsible. When you take the reverse transcriptase out of its normal conformational shape, it can't perform its action of elongating the strands here. So now moving on to the integration and integrase strand transfer inhibitors. This is a class that's probably going to grow over the years because I'm going to only show you one step, the strand transfer. But these drugs actually take multiple steps before they're activated, or the HIV integration process, I should say, has multiple steps and multiple potential places where they can be inhibited. So here's a quick question for you. After HIV RNA is converted to HIV DNA, it is integrated into the host DNA. What is the integrated HIV DNA referred to as? Is it proviral DNA, host viral integron, syngenomic HIV DNA, or splicer HIV DNA? Okay, great. I think you can close that down. Most of you have got that. It's proviral DNA, as I'll go over in a second and show you why that's so important. Okay. You want to close that down? Great. So the HIV integrase is an enzyme that has a couple of key structural components. At the top, the C-terminal domain, the N-terminal domain below it, but the area that's sort of the business end that we're interested in is the bottom base of it called the catalytic triad, and that's where the integrase strand transfer inhibitors are going to bind to. So the process, now we're looking inside the host cell, we're looking into the nucleus, and we're imagining that the virus has already made its way into the nucleus of the cell. The viral DNA, its RNA's turned to DNA, and the DNA has essentially got these two integrase dyads on there that are basically responsible for stitching open the host DNA. So what happens is the HIV integrase molecules come in. Essentially, they have these hot spots that they identify. It's almost like a unwelding process where they open up the host DNA, allow the virus DNA to essentially be stitched in. The host enzymes come in and smooth all this over. The HIV integrase enzymes are essentially removed from this process, and the final result is the virus DNA is now integrated into the host DNA. Once it's integrated, it's called proviral HIV DNA. And this is why we can't cure people unless we go to unbelievably heroic measures with bone marrow transplant with conventional therapies. It's because this is on the hard drive of the host cells throughout the body and many latently infected cells. Now, the integrase strand transfer inhibitors bind to this key pocket area where the catalytic triad is, and by binding into this area, what they essentially do is they block that opening up and essentially the identifying of the hot spots on that host DNA, and really this strand transfer. This transfer of the HIV DNA cannot occur. Now, let me finish by closing with just the HIV proteolytic processing steps and HIV protease inhibitor. And this is one class I think is a little bit misunderstood because we think of it schematically as occurring earlier in the cycle. Much of this actually occurs as the virus is leaving and has already budded off from the cell. So the HIV protease enzyme occurs in several different conformational shapes: an open shape, a semi-open shape, and a closed shape. And you can think of this as like a molecular meat cleaver that in its moving from the open to closed space can cleave polyproteins and open essentially these spaces up, and by opening and closing can cleave the polyproteins. And this is schematically showing you the most important places where HIV protease works. It works on these polyproteins that HIV synthesizes and transcribes, the GAG-POL polyprotein and the GAG polyprotein. And interestingly, the protease has a very logical sequence that it consistently follows in an order where it makes these cuts, and it's very important that this process occurs in an orderly way. Now, as the HIV is starting to bud off from the cell, these polyproteins and the GAG polyproteins and GAG-POL accumulate almost like spokes in a wheel of a bicycle. And this is very important because the HIV protease is working as the virus is leaving the cell and afterwards. And as Mike's showing here, these are the places all in this budding virus where the HIV protease is going to start cutting. And in the next slide, that's exactly what you start to see. And this is schematic, doesn't exactly occur like this, but basically the result is all of these polyproteins eventually are cut in certain places, and this frees up the actual budding particle to then have the conformational conglomeration that occurs to form a mature virion after it's left the cell. So the HIV protease inhibitors are much more analogous to the non-nucleoside reverse transcriptase inhibitors, where they're getting in there and they're directly binding to the viral enzyme and jamming up. So think of it jamming up like this molecular meat cleaver at the base of the protease enzyme. And essentially, these steps and these places of action are all points of interaction. You're going to hear more about some of the drugs. So I just wanted to conclude on a couple key points. As you've seen, the HIV has a multi-step complex life cycle. There are three key enzymes that we commonly use drugs to inhibit: the reverse transcriptase, the integrase, and the protease. And the most commonly used drugs used in clinical practice now, you're going to be seeing them focused on these key target enzymes. So let me turn it over to Mike at this point.
Great. Thanks so much, David. Great job. So we're going to take this information and now apply it to clinical care, and we're going to focus on these 4 areas: starting therapy initially, what to do with folks who have persistent low-level viremia, some issues about pregnant women or those considering pregnancy, and those individuals who experience virologic failure and potentially develop resistant virus. A lot of resources for you. The AIDS Info site has a lot of guidelines, including the HHS guidelines for use of antiretroviral agents in adults and adolescents. There's the IAS-USA guidelines that came out last summer in JAMA. And all of them pretty much say the same thing with a few nuances, and I'll try to point those out as we go. But the bottom line is, whereas years ago we talked about when to start therapy, now that's not so much of a question anymore. We want to start therapy as soon as possible. And rapid start is becoming quite popular in a lot of clinics. My personal view at the end of the day on this is that we want to be able to get people, once a time they test positive, into a treatment center within at least about a week or sooner. And so some people are getting them in within a day or two and then starting therapy right away. If you get them into the clinic in, say, 2 or 3 days and they aren't quite ready to start, that's okay. Bring them back within a week and then you can start therapy. The other advantage of waiting just a bit is that you can get all this information back in terms of the CD4 count, the viral load, the HLA-B5701, which, for those of you who aren't familiar, that's a haplotype of the cells that, if it's positive, indicates that there'll be a drug interaction with abacavir, that if they're rechallenged after starting, they could have a fatal type of hyperimmune reaction. So you use abacavir with those who are HLA-B5701 negative, and the ART, again, should be started as soon as possible. These are the types of tests that we get at baseline: HIV RNA level, CD4 count, a resistance test, the B5701 safety test, which includes basic creatinine and other liver enzyme tests. And then we always are screening for co-infections, especially STIs, tuberculosis, hepatitis, because if somebody's hepatitis B positive, we really need them to be on a tenofovir-containing regimen, and then, of course, health maintenance. So what regimen should you use as initial therapy? So let's take a case. This is a 48-year-old guy, presents newly diagnosed. His HIV RNA is 28,000. His CD4 count is 650. He's B5701 positive. He's got wild-type virus. His medical history is negative, normal renal function, and he's okay to start therapy if you'd like. Which regimen would you choose? Let's go ahead and vote. Let you look these over. Okay, let's see what we got. So it looks like the majority of folks are going with an integrase inhibitor type regimen. The bictegravir is popular, as well as dolutegravir with TAF-FTC. Now this is one where there's actually an incorrect answer, and that is answer 2 that has abacavir you don't want to use in this setting because they have the B5701 positive. We're starting to see a little bit more use of low-dose efavirenz in a generic form. That's answer 1, and that would be an acceptable regimen for this individual if you chose to do that. And virtually all the other regimens are acceptable. So as David just reviewed, this is the life cycle, and we have lots of places to intervene, but I would like to stress that all antiretroviral therapy does is prevents an uninfected cell from becoming infected, either by blocking entry, reverse transcriptase integration. And you say, well, wait a minute, what about protease? Well, what that does is that virus is maturing and coming out of the cell. It's no longer infectious for the neighboring cell, so that cell now is going to be protected because the integrase inhibitor blocked this. Now, this particular cell would have become infected if it was a protease inhibitor alone, but of course we're using it usually with 2 nukes, and that is part of the rationale for combination therapy. So the current recommended regimens are the integrase inhibitors, and they're listed here. The HHS guidelines also recommends raltegravir, which can now be given once daily as 2 tablets of 600 milligrams and usually paired up with either tenofovir and tracitabine or potentially abacavir and 3-TC. The differences between TDF and TAF mostly it has to do with plasma levels. TDF is a precursor of tenofovir, and then the tenofovir is taken into the cell, and it requires higher levels in the bloodstream and the plasma to penetrate into the actual lymphoid cells where the action is taking place in terms of the antiviral activity. TAF has much, much lower plasma concentration, but is much more efficiently taken into the cell, and then once in the cell, it becomes the active component of tenofovir. One of the questions comes up, well, does bictegravir work as well or better than dolutegravir? And the answer is they're virtually interchangeable. This is a long study that was done now up to 96 weeks and shows, in essence, no difference. And so that's part of the reason why it's really a dealer's choice as to whatever you would choose to use in this case. But there are other regimens that are recommended if especially you don't want to choose an integrase inhibitor at this point. And these regimens are all listed here, and they're all just perfectly fine, and they can work well. It's just that the overall efficacy in the clinical trials for the more potent integrase inhibitors is somewhere in the order of 93% success rates, and that is just phenomenal in terms of what we used to see with other agents. So a new emerging theme is to use dolutegravir and 3-TC together. So in that first case, well, we don't have any resistance, we're not using abacavir. Would you use this? The viral load was about 20, 30,000. CD4 count was 650. Would you use it in this setting? Let's go ahead and vote here. Okay, let's look at the findings. It looks like it's split. A good portion of folks aren't sure, and that I think is an appropriate answer. But I think the data are now starting to emerge that says it's a reasonable choice, and it's a little bit simpler regimen, and it seems to work just fine in the majority of settings. And just to show you some of those data, this is looking at dolutegravir 3-TC versus dolutegravir with TDF-FTC. And again, look at the outcome. It's right around 93% to 91%, and that is statistically not different. And the 96-week data will be probably coming out in the meeting in Mexico City this summer, next month. And my sense is that these data will hold up, but we'll have to wait and see. So generally no difference, so reasonable choice, a more simplified regimen. And even though the numbers are very small here, it looks like even when the viral load is quite high at baseline, that the 2-drug combination works roughly about the same as the 3-drug combination. So I think this is a repeat. So let's go ahead and skip this. Somehow, I think I went backwards. Let's go to the next case. So 48-year-old guy shows up, newly diagnosed, asymptomatic except for some weight loss, has a very high viral load of 760,000 and a low CD4 count. Now this time he's HLA-B5701 negative wild-type virus, and everything else looks the same as our first case. So what regimen would you choose here? And I'm including a few changes like dolutegravir 3-TC here, and also including some other options. Go ahead and vote. Okay, and we'll broadcast that out. So it looks like we have similar results as last time. Some folks went with the dolutegravir 3-TC. Here, abacavir 3-TC dolutegravir is a fine choice. I think what's changed over the years is that answer number 9, which included a boosted PI, is polling at about 9%, whereas before there seemed to be a disconnect that that because of the history of the release of protease inhibitors, folks went with a protease inhibitor for high viral load, but as you saw from a lot of the last couple of slides, integrase inhibitors work just fine in that setting as well. The one regimen you wouldn't want to use, and actually nobody picked, was rilpivirine. That's a drug that you only want to use when the viral load is less than 100,000 copies. So great job there. So this is looking at viral efficacy of less than 50 when the baseline viral load is greater than 100,000. And this is the same study I showed you before, and you can see that again, BIC and dolutegravir both work, all work about the same, regardless of the backbone. Same sort of data right here. So now here's an interesting question. Which drug is most likely to cause a 0.1 milligram per deciliter jump in serum creatinine 1 week after starting therapy? Choices between bictegravir, TDF, TAF, azanavir, or emtricitabine. And this is one of those pretest questions that I think you might have answered before. Okay, so it looks like 31% got the answer correct, and that is the answer is bictegravir. A lot of people are surprised at that. The bottom line is that it's very important to understand that when we think about GFR, glomerular filtration rate, we're again thinking about the glomerulus, but there's a few other subtle ways that creatinine can get from the plasma into the urine. And these are in the proximal tubule cells right here. This is plasma, this is urine. There are two transport systems, and the one at play here is one called OCT2. And OCT2 secretes creatinine from the plasma into the urine, and that equates to a very small fraction, but real in terms of what the serum creatinine does. It's about a 0.1 to 0.15 milligram per deciliter difference. Interestingly, cobicistat, through a different mechanism, has a similar effect on through the enzyme called MATE1. And the way this translates, you can see in the study here early on with dolutegravir, which has the same type of activity on OCT2, that you can see right away, and it's universal. Every patient basically on the study had a bump in serum creatinine within 1 week after starting a dolutegravir regimen. Same type of thing was seen with bictegravir. Just kind of interesting and important, because if you're following somebody, you put them on an integrase inhibitor like BIC or dolutegravir, you're going to see that little bump, so don't get concerned that it's a toxicity. It's just an expected effect. So what do we do with somebody who presents with a genetic mutation at baseline? So this is a 30-year-old lady who comes in, has a viral load of 128,000, CD4 count of 350, B5701 negative. She actually has two mutations here, M184V for 3TC and FTC, and a K103N for non-nukes, in particular efavirenz. It's okay to start therapy if you think she should, so what are you going to use here? Here are your choices. There's an efavirenz-based regimen. There's a dolutegravir 3TC. There's a bacavir with dolutegravir, etc. Let's go ahead and see how we turned out here. So it looks like, again, the majority have gone with answer 6. Here we have a couple of wrong answers again. Anytime you're using dolutegravir with 3TC, and I haven't said this before because I knew this question was coming up, if you have an M184V mutation, you do not use the dual drug combination. Do not use dolutegravir 3TC when there's a baseline M184V, because in essence you're giving something close to dolutegravir monotherapy. So answer number 2 would be an incorrect answer in this case. Also, answer number 3 is a little bit weaker because you've kind of had an impact on obviously the 3-TC, but abacavir also takes a small hit. So in this case, answer 4, if you want to use dolutegravir, would be a better choice in that setting. And the rest of these other choices are generally pretty good, except for answer 1, which includes efavirenz, which would have lost its activity. And I tried to give you that hint as we went through the case presentation. So once you have somebody on therapy, you're going to monitor HIV RNA kind of frequently in the first 6 months. Then you'll stretch it out to every 3 months. And ultimately, once somebody's doing well for a year or so and they're been undetectable consistently, our site usually goes to every 6 months, and most people do. CD4 counts, you can continue to follow if they've been lower than 250. Follow them out for a year. But if somebody's consistently suppressed and the CD4 count goes above 250 or 300, you don't really need to check CD4s anymore. It saves a little bit of money. I know HRSA has not quite embraced that just yet, but I think they should, and so you can maybe get in trouble on your reports to HRSA, but it's really, I think, medically the right thing to do. We don't do anything different based on a CD4 count above 350 when the viral load is suppressed. The V5701, only if you're going to be switching and you haven't determined it previously. Remember, this is a cellular marker, so it ain't going to change unless, I guess, they have a bone marrow transplant or something. Safety testing, and then, of course, the STI testing over time is very important. Now, one thing about the data here is that a pre-existing M184V, when you're starting to use integrase inhibitors, does not really impact the activity of the initial regimen, or even transitioning to another regimen in the case of virologic failure. And so the bottom line is we haven't lost 3-TC and FTC when there's an M184V, which is a resistance mutation for those drugs. It's not 100% loss. Rather, it's a partial loss of activity. There's still some activity, and the integrase inhibitors are powerful enough, especially when there's either tenofovir or another drug on board. So let's transition now to women in particular who is either pregnant or considering pregnancy. So the story is, here's this same lady, more or less, who we saw before. She's already on an ARV regimen. She'd like to become infected. She's infected. She wants to become pregnant while she's HIV infected. She's asymptomatic. The labs are normal. She's currently on dolutegravir, abacavir, and 3-TC and is doing remarkably well. So what do? Do you keep her on her current regimen, or do you switch her to something else? And there are your choices down there. So let's go ahead and vote. We can have the question up. Not sure we have this one. Well, you can imagine what it would be, what you would do. And I think there's actually debate on this one. In the interest of time, I'm just going to move on. And a couple things. So far, there's not enough data on TAF. And so we typically would not recommend using TAF initially. It's mostly a concern of the actual drug level of the tenofovir active moiety is a little bit higher for TAF compared to TDF. At the end of the day, my bet is that there won't be any clinical difference, but I think there needs to be a little bit more data available. The bigger concern that's come around is a study out of Botswana that showed that there were a few more neurotube defects occurring. It's one of the more common birth defects that occur in infants worldwide, but there was 4 cases out of 426 were noted to have this issue, and led to a major concern. So most folks, until there are more data, and I think we're going to see some more at Mexico City and perhaps at the IAS-USA meeting, my bet is that this number is going to come down from, or it's already dropped from 0.94 to 0.6 something. You can see the comparators here. The bottom line is that I think in this setting, I would just talk with the patient, see what she thought about continuing on her current regimen or not. And if she plans to become pregnant, give her folate. The folate likely will protect against this. There's no data about the folate in the 4 individuals, but my strong suspicion is that these individuals who had babies with neurotube defects were not on folate at the time of conception. And also remember that the neural tube closes by week 6. So mom's already pregnant, and let's say she's out to week 10, and she's already on dolutegravir, you might as well continue it, because if there was any harm effect, it would have already have happened. She's entering prenatal care there, and so then you can continue it on. This is the update I was referring to, and you can see the value had already dropped to 0.67, and we'll see what the next data show. Raltegravir, I'll mention, is safe to use. So if you wanted to switch over to another integrase inhibitor, that's one I would use. There are no data yet on bictegravir, so it's generally avoided until there are more data, sort of like TAF. Are you committing a terrible mistake if somebody gets pregnant while they're on bictegravir and TAF? No, I just think if you're planning ahead, you'd probably want to use either raltegravir, darunavir, or atazanavir are really good background regimens in this setting. So what do I do if somebody has a discordant CD4 response? So this is kind of common. A man presents, newly diagnosed, he had a viral load that was high and a CD4 count that was low, about 24, started on therapy, and 1 year later his viral load's less than 20, so that's good response, but his CD4 count only jumped to 65. So should you change therapy now? Yes, no, or not sure? Okay. It looks like the majority of you would do what I'd do, and that is I would not change therapy. Remember, as I said before, the reason to use antiretroviral therapy is to stop all ongoing replication of virus going from one cell to another. You have incredible evidence here that you've been successful at that. The viral load has dropped less than 20, target not detected, perhaps, and so there's no ongoing replication that can be distinguished. So changing the regimen isn't going to affect this at all. What this is a situation where the patient has had no release of CD4 cells that likely were trapped in lymphoid tissue from all the ongoing replication in that tissue, with the elaboration of adhesion molecules, et cetera, that kind of trap the cells inside the tissue. And when you give antiretroviral therapy, that trapping stops suddenly, and then those cells are released into circulation. And the folks who have this type of discordant response, their lymphoid architecture has probably been destroyed, and so there's no release of cells, and so their CD4 count just rises gently and slowly over time, and so changing antiretroviral therapy is not going to change that biologic phenomena. And here's an example of this on a slide. So you have the typical story where you suppress virus here, and at 6 weeks, that normally the CD4 count is bumped to 150 to 200 cells. This is that release. The type of patient we just saw did not have that bump because there wasn't that release of cells. And so if you notice carefully, I drew this as well as I could with PowerPoint, that the slope of this line is virtually the same as the slope of this line. So the replacement or the regrowth or the repopulation of CD4s in the absence of ongoing replication is roughly the same. What this person missed was that bump. Should I change a regimen when the low-level viral detection is there? So this is a story of a 55-year-old guy, been on treatment for over 18 years, had a very high viral load at baseline, now has got a viral load of 85, his prior value was 62. CD4 count has come up nicely over the 18 years, started on a bunch of the older regimens, but now is on a dolutegravir, darunavir that's boosted, and a 3TC. This is not exactly an approved regimen. A lot of people use it. I'm not advocating it. It's called double D. Seems to work, but I don't think there are no data, and there was a problem with raltegravir and darunavir that gives me a little bit of pause before I pull the trigger on that, but anyway, that's what this guy is on. So would you change therapy now? Yes, no, not sure. Okay. So some uncertainty here. some folks would change. The actual data show that anytime you have viral load less than 200 and certainly less than 100, that is not evidence of ongoing de novo replication. So the drugs are doing their job. This is just the virus sort of inside of the cell, chronically infected as a proviral state. We had that definition earlier. And the provirus kicks out virus every now and then, and that's how we end up seeing so residual viremia. And there's just some people who just never clear. Changing their regimen or intensifying by just adding another drug doesn't change the fact, and they would end up staying somewhere between 50 and 100 copies, and you just kind of let that go. There's no evolution of resistance, and usually those patients do quite well. And this is an example using the slides from the National HIV Curriculum that David organizes. Here's our normal state, which you look for, and on the next slide you can see every now and then there's a blip. That's where virus is stimulated to be released. It doesn't mean that there's de novo replication, just something that happens when those proviral cells get stimulated. And there are some patients who over time, will just sort of maintain a level of viremia that's detectable, and it stays steady. It doesn't go up. That's the key point. And I would like to point out here is that, again, like I said before, when we give, if you have infected cells at the top, and they are producing virus and infecting uninfected cells, you get this vicious cycle that antiretroviral therapy blocks. So that blocks all that de novo replication. These cells die off, and as they die off, the viral load drops proportionately because viral load is directly proportional to the number of cells in the body producing virus. Where does the viremia come from? Well, it comes from these cells up here, the latently infected CD4 cells that have a provirus that they can live on average for months to years, and if they get stimulated with an antigen or whatever, they then will kick out virus that can be detectable, but the antiretroviral therapy is still working, so you'll detect it in the bloodstream. You just won't have any impact. These cells are precisely the ones that are interfering with our ability to cure. Until we can figure out a way to get rid of these guys, we aren't going to cure anybody. And this is an example now of what happens when there's an increase. What you want to do is repeat that, and if it's starting to rise, and especially if it goes above 200, that would be the definition of virologic failure. Here is where you do have ongoing or newly recurring viral replication in the face of antiretroviral therapy, and if you let that go on too long, it's a recipe for resistance development because it'll start to select, under selective pressure, it'll start to select for viruses that have a growth advantage with those drugs on board. So what do you do when you encounter virologic failure? First off, if you have the bump, especially if it's above 100, you're going to bring them back in a week or so, repeat, and if it's going up, and especially if it's gone above 200, then you're going to get a resistance test, and based on that resistance test, you'll pick another regimen. A lot of times, dolutegravir or bictegravir regimen is quite effective there. We've already mentioned about the 3TC mutations still being okay. A boosted PI is also a good regimen in this setting. And you want to have, if they're still dolutegravir or integrase inhibitor susceptible, then you want to have at least one other fully active drug with either that or bictegravir. Sometimes there can be raltegravir or alvategravir resistance present, of which dolutegravir still is technically susceptible, but in that setting, we want to use dolutegravir twice daily. And in that setting, bictegravir is really not an option because it's only available to be given once a day. So in the setting, continuing on at virologic failure, get an HIV RNA, a CD4 count, the genotype or phenotype, depending on the situation, and then you want to go ahead and do safety testing at that point as well. Switch your regimen, and then once you switch the regimen, you go right back to what you were doing here, with the exception of the B5701. You're going to follow more carefully over 6 weeks than 3 months and make sure that the new regimen is working. So now you have a patient, they're undetectable. How do you advise them about risk for transmission? So here's a person who was treated successfully, started on ARVs, returns 3 months later, now has got undetectable virus, and a CD4 count that bumped like we'd like. So, assuming he remains undetectable, you tell him that his risk of transmitting HIV through sexual activity to a seronegative partner is what? Okay, let's see what we got. So, I think answers 1 and 2 are really the right answers. It is about as close to zero risk as you can get. There are now a number of studies, the Partners 1, Partners 2 study, that show no transmissions. The problem is that when you look at the upper end of the confidence interval, there may be a chance, maybe theoretically, that there could be a transmission, but in essence, assuming their viral load stays undetectable, they're not going to transmit the virus to someone else. You could, if you're really conservative, you could say, yeah, it's very low risk, but I found that patients, I usually use the word virtually. It's virtually zero risk. The no one knows for sure, I think we could always say, but I think we do know for sure by now that there's virtually zero risk, assuming they stay undetectable. And so these are the data from the partner study that I was just referring to, and you can see that there were no transmissions based on over a long period of time of observation, and this is up to 76,000 individuals who were followed. Depending on the subgroup, this is looking now, there are zero transmissions, right? But based on the number of people, the upper end of the confidence interval, it's hard to get that. You can't get that all the way to zero because you just can't follow enough people to do that. But statistically, it's really a virtually zero risk. And that's where this term U equals U comes up, undetectable equals untransmissible, and that's the message I wanted to leave you with, that that's one of the great things about antiretroviral therapy today. When we treat successfully, patients go undetectable. They will live a normal lifespan for the most part, and a healthy life, but they also will not transmit the virus to other people, and that's something we can all celebrate, and that's the way we can start bending the curve of transmissions in the United States to get close to zero. So ARV therapy should be initiated with an integrase inhibitor-based regimen in general. Do not change therapy in the setting of low-level viremia, assuming it's persistent and not rising. Use either dolutegravir, BIC, TAF, COBI cautiously in women contemplating pregnancy. The M184V does not have much impact on INSTI-based regimens, integrase inhibitors. No benefit to switching ARVs for those with discordant CD4 count responses. The new therapy following virologic failure is determined by the resistance test results and the tolerability of prior therapy, and a desire or not for a single tablet regimen. That's what STR means, single tablet. A lot of times patients don't, they're more, I think, concerned about once a day versus more than once a day than they are about single tablet, but it's all individual. And then, of course, U equals U. So at this point, we were successful in leaving well over 15 minutes for questions and answers. So we're going to follow up here with our post-test. Following acquisition of HIV, when is plasma HIV first detectable? David covered this pretty thoroughly. We will give you a chance to affirm his teaching skills by showing that you were paying attention. Let's go ahead and see what we got. Okay, and boom, folks actually were listening. It's fantastic. And then let's look at the next slide. Which one of the following HIV inhibits by binding to the CD4 receptor at the D2 region? That D2 region, all that detail that David went over. Okay. And again, folks were listening very carefully. So a lot of change and improvement in the responses here. So great job on that. Remember, Maraviroc blocks CCR5, and Fuvertide is at HR1, HR2 interference with GP41. Bictegravir is an integrase inhibitor, which has very little to do with CD4 binding. In fact, nothing to do with that. So let's go ahead and go to the Q&A, and we're going to get to as many of the questions as we can. I'll read it off in between David and I will answer them. Here's the first question. What is the explanation for genetic susceptibility to HIV and HIV drug resistance development? David, you want to take that one?
Well, the genetic susceptibility of HIV, the thing we know the most about acquisition, it has to do with the host co-receptors. And this is how the whole process led to the discovery of Maraviroc, is there are a very small percentage of people, less than 1%, who genetically are missing a component of the CCR5 receptor called the delta 32 region. So when they are missing, the delta 32 means they're missing 32 segments of the amino acids in there, and those individuals, if they're homozygous for it, are essentially not able to contract HIV. And in terms of acquisition of HIV, that's the factor we know the most about genetically. Now, once someone's infected, Bruce Walker's group has shown that the host CD8 response is related to genetics of HLA typing, or HLA is probably the single biggest factor that, for example, determines that people are going to be elite controllers, or that's associated with elite controllers. But in terms of acquisition, the host co-receptor is probably the biggest factor. I don't know if you want to add anything to that, though, Mike.
Yeah, and the second part of the question is about drug resistance development, which is different, right? So that's resistance to the drugs themselves, and there are mutations. If you think back to the cartoonograms that David showed, for example, of reverse transcriptase, in that little hand where the thumb moves, well, the binding site where the drug drops in, that binding site can have just one mutation, for example, that K103N for efavirenz, and it just won't bind there efficiently anymore, and therefore the virus can still replicate because the RT is functional, reverse transcriptase functional. It's just that that mutation does not allow the drug to block, and the virus at that point is resistant to at least that drug, in this case efavirenz. So let me go to this next question about HLA. So some docs are saying, we don't need to get an HLA on newly diagnosed patients anymore. Can you offer an opinion? I personally get it because it goes in the chart, and if we ever want to use abacavir, we don't have to wait for the result to come back. It's there. We can make a decision. It opens up the armamentarium from my perspective. It's something that's not all that expensive, and I think the money that we're saving on not getting CD4 counts as well would well pay for that. So I personally do it, and our clinic does. Yes, Dave?
Yeah, and I would just add that if you're considering using abacavir, that is non-negotiable. You absolutely need to get an HLA-B5701. The question is really only maybe related to, well, we use so much TAF and TDF now, maybe you don't need it. But if you were considering using abacavir, I think every person would that would recommend this would say to get a HLA-B5701.
Yeah, and at some point, if somebody has advanced renal failure, then abacavir becomes a good choice for a drug, and it becomes difficult even to use TAF in some settings. So, David, here's a question for you. Why can't HIV viral load be used as the sole way to diagnose HIV since it's the earliest detected?
Yeah, this is a really interesting question. So, now probably the earliest practical test is the p24 antigen antibody combination assay, and that does not detect HIV quite as early as the HIV RNA, but the HIV RNA test alone is not a very practical test in terms of cost and turnaround time, at least with commercial labs in the U.S. And the second thing is, if you just use an HIV RNA, you will miss a rare number of people that are infected with HIV, so-called elite controllers, who truly have undetectable virus. So having antibody as part of your test is very important. I will say that there are some point-of-care tests that are being developed that actually have HIV, RNA, and antibody combined. That, to me, would be more attractive than just HIV, RNA alone as a diagnostic test. And, yeah, I think that could be there in the future, and it's a really good question.
Yeah, I think it has to do with throughput and cost at the end of the day, but you're going to be picking up 99.9% of the infected patients. The only ones you would miss would be in that very, very eclipse stage that David talked about. So here's another question. Can you talk about when you would use once-a-day raltegravir? Well, number one, I'd use it all the time if I'm going to use raltegravir. I just think it's a better choice than twice-a-day raltegravir. So it'd be 600 milligram tablets, 2 of them once a day. I think a great setting for this would be anytime we want to minimize or have a situation where there's minimal drug-drug interactions. Raltegravir is mostly glucuronidated, so it doesn't interfere with most of the CYP350, 360 enzyme. In other words, like CYP3A4, CYP2D6, the pharmacists are following along for sure here when I'm talking. But the bottom line is those are the things that are heavily involved with drug-drug interaction. So raltegravir doesn't have much metabolism that way or have much of an impact on those isoenzymes, the cytochrome P50 system. So it's a great drug there. We also mentioned earlier that it's found to be safe in pregnancy. So a woman who is contemplating becoming pregnant, it's a good go-to drug. And if I were using it, I would use it once a day. And there may be some data about the placenta. That's the one thing that I don't remember the details.
And Mike, I would just add, currently the guidelines, HHH guidelines, really recommend using BID in pregnancy.
Right, for pregnancy.
The other drug, and the other drug that's interesting that you really should use BID in pregnancy and not once a day is darunavir.
Yes.
So just kind of a couple take-home points with pregnancy are, darunavir and raltegravir are supposed to be used in the BID, and you're supposed to avoid cobicistat and rilpivirine during pregnancy, and that has to do with different issues, or the same issues, but related to drug levels and not so much concern for toxicity. So people on elbowtegravir regimens and rilpivirine regimens, there's bigger concerns with second and third trimester with levels, and those are not considered recommended in pregnancy.
Right. So one quick question, when do you use phenotypic testing? Well, I hardly order it anymore. In the older days when we had more complexity with trying to choose protease inhibitors, I found it to be helpful. But most of the times from a genotype alone, I can figure out what the susceptible drugs would be. The place where I found phenotypic testing the most helpful is in trying to differentiate between activity of protease inhibitors when they've been through it, patients been through a couple. But to be honest, darunavir is really the go-to protease inhibitor these days, and it works against a lot of viruses that have some early protease inhibitor resistance mutations. So I don't find it all that helpful anymore. It doesn't work, phenotype doesn't work all that well for distinguishing nucleosides and nucleotides. A little bit helpful for hypersusceptibility, but you can guess that anyway by just knowing some of the mutations. And for integrase, there's only a few key mutations, and you can go. One thing to keep in mind, the Stanford University website is a wonderful resource where you can just plug in the mutations that you come back, the genotypes, and it will give you of virtual susceptibility all on the spot, so you don't have to have an expert available to you all the time. When in doubt, though, if you have a complex case, always reach out to others, and you can, at other sites, you can call reach out to the IAS-USA or other places. We can try to get you in touch with somebody. So, Dr. Spach, is a leak controller status passed on perinatally?
So that's interesting. So a leak controller status, from what we know, is really mostly related, again, to the host CD8 responses and HLA types. So theoretically, there should be some transmission from parent to child or from mother to child, but like any other genetic trait, it's not 100% transmissible or reliable. Interestingly, women who are elite controllers should be very, very unlikely to pass on HIV to their child because, as we know, the definition or people with elite control of HIV have very low levels of virus in their blood or undetectable. And that's clearly a factor, the single most important factor with perinatal transmission. And if you have a very low or undetectable virus, as a mother, you are very unlikely to pass this on to your child. So I think it's an interesting question, but practically probably doesn't come into play because of the unlikelihood that someone would pass on HIV to their child.
And a related question is an opinion about whether we should treat elite controllers. And wow, that's really loaded because I think what's happening there is that the immune system in those individuals is so efficient at controlling replication that you don't detect viremia. On the other hand, it's still the immune system working. It's still having to work hard to keep the virus under control. And we know that over time, some of the longer-term complications are related to inflammation from the onslaught daily of ongoing replication in the immune system's attempt to respond. The bottom line answer is we don't know. So there's a lot of opinion about this, and indeed, some of the cure research these days is focusing on something called virtual cure, which in essence is converting someone biologically to an elite controller status by either vaccine or some other immune system intervention. So I don't think we know the answer, but my tendency is to lean towards treating them as opposed to just watching over time. So we have another question here. Do patients on Bactrim and azithromycin, do you keep them on that with a low CD4? Dave?
Yeah, so interestingly, nowadays, with both the IAS-USA led the way on this, and now the HH guidelines led this, that we're not always initiating azithromycin in people newly diagnosed with HIV with a very low CD4 count, who we normally, in the past, would have put on azithromycin for MAC prophylaxis. Now, I think most experts are saying if you see somebody with advanced HIV, CD4 count less than 50, which is the cutoff for MAC prophylaxis, and you're going to start them on antiretroviral therapy, their risk of developing MAC is so low if you're going to start them on antiretroviral therapy that you're not really gaining anything. So I am very quick to pull people off of azithromycin if they did get started on it for prophylaxis. Now, the issue really with and I think now I'm generally not starting azithromycin, and Mike really led the way on this with IAS-USA, and I think that's what most people in practice are doing now, is not starting azithromycin if you're starting antiretroviral therapy. Now, one of the questions, probably the more relevant one, is what about stopping trimsulfa? And I think there's pretty clear data that if a person has a CD4 count above 100 and they have a suppressed virus for at least 3 months, those individuals can actually stop their trimsulfa even if they previously had pneumocystis. Above 200 and suppressed virus, we've been very comfortable for years stopping PCP prophylaxis, stopping trimsulfa. But I would say now, both in the HHS guidelines and IAS-USA and in clinical practice, we're seeing most people stop trimsulfa with CD4 counts above 100 if they've been above that for at least 3 months in the setting of suppressed virus on antiretroviral therapy. And I don't know if you want to add to that, Mike.
No, I agree completely. Another question kind of reiterates one of the cases we had, was if you have somebody who's got a persistently low CD4 count but are virally suppressed, would you change their ARV regimen? And the answer to that typically is no, unless there's some toxicity. But no, just for the fact that the CD4 count didn't rise, I wouldn't do that.
And I would just say, Mike, this issue used to come up with when people years ago were on AZT, and that was a drug that I would clearly switch people off, but we just don't hardly see anybody on AZT anymore.
Yeah. There's a question here about how do you interpret low-level resistance in the Stanford database, especially when GenaSure, which is a trade name for interpretation, does not indicate resistance. So you got quote, low-level resistance. How do you approach that, Dave?
So I think it depends on the drug and what we're talking about, and that's a hard question to answer just point blank, but I think it should give you pause to, for example, if it's a low-level resistance to a drug like rilpivirine with a low genetic barrier to resistance, that would make me very concerned, and I would certainly not use that as the only anchor drug in a regimen if I saw that. On the other hand, low-level resistance to a drug like darunavir, that drug will probably still have a lot of activity and it has such a high genetic barrier to resistance. I think where this most practically comes up, for example, is seeing low-level resistance with a couple TAMs to tenofovir, and I think in that case, one of the things to look at is what the score looks like along with emtricitabine or with the 184 mutation and how the combination tenofovir plus emtricitabine or TAF plus emtricitabine looks, because the 184 will actually make them hyper-susceptible to the tenofovir, which essentially sort of negates some of that low-level resistance. But I think it really depends on what the drug is and what the setting is. Mike, you may want to add something to that.
Yeah, no, I agree. It is complicated, and it's kind of hard, especially in, for example, a 101 sort of course. I'm thinking about the people who are getting into the field and we're listening to this conversation and kind of probably getting a little overwhelmed, but the take-home point is that it's all individualized. When you get resistance data, then that relates to the next question, which is in treatment-experienced patients, can you use a combination of boosted darunavir with BIC, TAF, FTC? And the answer is sure, you can use that, but again, it's going to be based on the resistance assay. And the one thing that you might be able to get by with perhaps, in this case, darunavir with dolutegravir, maybe one other drug. With BIC, you're sort of committed to the three drugs together. But on the other hand, that regimen likely would work in a number of settings. The question is, would it be overkill? And that depends on what the resistance test says. We only have about maybe a half a minute left, and so there's one question here about...
Just
go ahead.
2 seconds. Undetectable now mean vaginal birth? The answer to that is yes. Viral load under 1,000, generally avoiding cesarean section now.
Yeah. So I think we're going to have to close here. We had a couple of questions about general comments on drug class-specific side effects. And I suspect the best place to go for that, it's a little bit of a conflict of interest for me, but the Sanford Guide has great descriptions of all that. Actually, the HHS guidelines has a number of tables that show this, so that'd be a very accessible place to go look for that answer. And so, unfortunately, it's the bottom of the hour here, and we're going to have to start closing up. It has been great questions and a great webinar. Time went by, as we thought, very quickly. This webinar will be available for on-demand viewing and CME credits at the IAS-USA archived webinars part of the website. A CME credit cannot be claimed for both live and archived, but if you have a colleague who missed this and wants to go online and listen to it, watch it, they can, and they can still get CME credit, but unfortunately we can't have any double dipping, sorry. Evaluations, 5 p.m. today Pacific time, somewhere I've heard this before, and then you can go online and process. The common question after these things is people go right online to say, I can't find it. Well, you won't find it until 8 p.m. Eastern tonight. Yeah, we'll skip this question. I think we just made the point. And then upcoming webinars, a lot of really good ones here for pre-exposure prophylaxis. Rafi Landovitz is perhaps the world's leading expert in this, and you can really benefit from interacting with him. He's very lively and good presenter. Similarly, Katie Barr at UPenn is going to talk about cure strategies, and that would be a great place to follow back up with the questions on functional cure and elite controllers. Victor Valcourt at UCSF is going to be talking about HIV and the aging brain. And the good news is, in all this antiretroviral therapy, we've got people living into their late 60s and early 70s and even into their 80s, but then the question is, like all of us as we get older, what happens to cognitive function, and he's going to talk about that. And then switching gears a little bit, Andrea Cox is going to be talking about the global control of hepatitis C and ways to eradicate this virus from the globe. Coming up in New York City in September on the 12th, Trip Gulick and Jeannie Marazzo are going to start a brand new IAS-USA live course about sexual health, HIV prevention, and primary care. A whole new initiative. Those of you who are in the primary care environments and would like to get a comprehensive approach, especially on the prevention side of things, how to take folks and keep them from becoming HIV infected and also dealing with STIs and that type of thing, use of PrEP, the whole day will be focused on that. And if you want to get a trip to New York City, it'd be a great time to go, and you could see this live presentation and then maybe catch a Broadway show or something. Other resources, this is all from CROI. As you know, IAS-USA is the conference secretariat for CROI, organizes the meeting, and there's a number of great reviews, especially the topics in antiviral medicine that have the abstracts, but also there's a number of summaries that have been published, and these are all available on the IAS-USA website. And you can go to the CROI website for broadcast, webcast of the actual presentations. It's really it's a remarkably functional website for CROI, and you can hyperlink there from the IAS-USA website if you'd like. Mentioning topics in antiviral medicine, these are the reviews I alluded to a second ago, and you can see they're quite comprehensive, going from basic